if we have an OHP group running, we would usually bring a doctor in to talk about medication, not specific for the individual, but general generic points can be raised in a group setting. And that's really quite a helpful thing for a lot of people. You do help people to take the medication regime and document that. And this is the metabolic monitoring, which I talked about. So again, I think empowering the patient by giving this to them so they have their own record is really important. And it also gives the guidelines about what you should do. Talks about these generic issues, lifestyle issues, the blood test monitoring and so forth. And then talks about reasons why you might use medications. And, you know, often people have, well, pretty much everybody you'll ever come across has used medications at some time in their life for something. You can brainstorm with them about why you might wish to have medications and why you might wish not to have medications. I've got a fascinating patient at the moment in Hobart who has a lot of different symptoms, but just is so ambivalent about medications that she will only take the teeniest, weeniest dose of anything. And it's fascinating to, you know, you could just get exasperated and say, well, goodness gracious, you're coming to me and I'm suggesting you take this medication for all these symptoms you're talking to me about, but you don't want to do that. So, you know, go and see someone else. And in fact, that's something which had happened numerous times to her. So she's been through, I don't know how many physicians who basically she gets that message from and never goes back. So what do you do with that? Well, you say, why do you think I might be wishing for you to at least consider medications? This is motivational interviewing, really. Let's brainstorm what you think they might do. You know, people have all sorts of fantasies about these things, either positive or negative, that they might, you know, be very dangerous for them, or that there might be, you know, a miracle, which is neither the case. We do also talk here, if necessary, about substance use, this is actually a separate module within OHP on substance use, and that's tailored to the particular substance. And in the medication information package, there's some information about substance use as well, and the medications which can be used for withdrawal and so forth. I won't discuss this too much here because we don't have time, and it's probably not the most appropriate thing for a lot of patients. Some people are needing this sort of work. If you feel comfortable with doing some of this, then that's fine. If you're not, then there might be other people within your team who might, or there might be other agencies you need to refer to. Then goes through all of these medications, the common side effects and how to deal with them. And this I've already stepped through with the previous information I've given you on the booklet. So that wraps up medications, and we also have an entree into substance use. Substance use often comes up when you're starting to talk about stress vulnerability and the I Can Do model, because people would say, you know, what do you currently do to ameliorate stress? And a lot of people, if they're honest, use alcohol in particular or other strategies. So there was an opportunity back then to talk about alcohol and pluses and minuses of alcohol, and don't just say, well, alcohol is a bad thing. Well, not a great drug in many ways, but it is used for something. So, and you need to understand why people use, the context in which they use, whether they think it's a problem or not, and then engage in a discussion about them, whether they think that this is something they would like to deal with. The example I've just given is one where using information from an earlier piece in the OHP path, so the session on stress vulnerability and the strategies you currently use in terms of management of stress can be brought forward into a later session here, session 4. Let's use session 5. Let's move on to session 5 and talk about partners and strategies. And this is where we start to talk about health plan 2, which is the plan where you start running into tricky territory. So this is the analogy of the road again, and where you are driving through the Black Spur and the road works and it's just dark and stormy night. You will have to slow down. You will have to make sure that you have anti-skid brakes, that you have checked the pressure in your tires, and that you are being extra vigilant and extra careful about how you are driving. So sometimes you know that you're going to head up against such problems. Sometimes they're just completely out of the blue. And you then acknowledge that no man is an island or no person is an island, and that you, for this, are the most important person, yes, but you do have a whole lot of people around you. And you can map those using this eco map. I do love this piece because it's not unique to OHP, by the way, but what we've done is to build it into the whole OHP strategy and built in some adaptations from its usual use. So it puts me, you, the person at the middle, and then builds in others and gives some indications about how common your interaction with that person is. So that's the F, whether they're supportive or not, what the relationship is like. And also you can place them either very close to you on this graphic or much further out. Or it might be out here in the, where Pluto is, because you just don't see them anymore. I gave the example last night of a patient who had a very close relationship with their mum, and their mum was a lot of interaction with their mum, but the dad had left under not very good circumstances when the person in the middle was very little and didn't have any contact. But it didn't mean that they didn't have an emotional connectedness, because they had all of that emotional memory of that person and had an assumption that that person didn't want anything to do with them. Actually, it was not true, and eventually, as part of the therapy process, actually reached out to the dad and connected with him, and he came into this circle. It was never a very close relationship going forward, but it was an emotionally balancing relationship in part of, if you look at this whole thing as requiring balance. So you can put in people within your family like that example, or you can put in your clinicians. So here's the GP. What do they do, and how often do you see them? Your brother, your mother, your family dog, whatever. And then this notion of directedness, direction of the support. So Paul gives me a lot of support, but I give my brother Tim a whole lot of support. But with Judy, it's a more difficult relationship, tenuous relationship. There's the dotted line, but it's pretty bi-directional. And of course, with Toby, it is an unambivalent, beautiful, bi-directional attachment. Very good things, dogs, if they behave. And it then builds on that. So it says, who are these people? Who are what are their functionalities? How does it look? Sometimes you get people say, I don't have anyone. And you say to them, well, that's interesting, because nobody has nobody, of course. You're thinking, but you can say, well, absolutely nobody, in trouble, who would you go to? And they would usually then acknowledge that there was somebody. And then you could say, well, I'm here in the room with you. Now that's a relationship, I suppose, on some level, at a therapeutic level. Do you think you might consider putting me on this map somewhere? You don't say, well, it's me, and you've forgotten about me, put me on your map. That isn't the way that discussion happens. you invite a discussion, and then that might usually is met by, okay, begrudgingly they might put you on the map, and then say, well, anyone else? And they said, well, if you're looking at it that way, well, there's also my GP, and there's, you know, this and that person. So that's the way to open up this discussion. And then you ask them what, when they would use those people, and what their expectation of those people can be. So this is a key part of it. It is not a unidirectional thing where you say, well, if I experience X and Y warning signs, I'm going to expect my GP to be available for me 24/7, and they're going to give me a whole lot of benzodiazepines. That's not going to be the way it's going to work. There has to be an expectation of the person using their own strategies first, and then a cascade of things which they would do, and then at a point in the cascade of things which they've tried, they might need to bring in a person, but the person has already had a discussion with them around how they will be involved. And the virtue of this is that nobody's caught on the hop because they've already rehearsed this. Also, if it works out, it's great. If it doesn't, you can go back and say what failed and what didn't work and what could be improved or done differently. And that's a separate tool, which I'll show you. And the other virtue of this is that there can be a discussion with the collaborative partner. So going back to the collaborative partnerships, here you're saying maybe, well, Paul, you're not just going to expect Paul to be available to you all the time and you can phone up and get a prescription. That's not the way it's going to work. Let's go and check out with Paul what he actually does think about all of this and what he thinks is going to be best in terms of his role, what you think is going to be best in terms of his role, and let's get that all documented and agreed. Okay, and that's what it allows you to do. So this is, if we were doing this as a workshop, you would actually complete your own eCoMap. I would suggest you guys do this. I'm sure for all of you wonderfully balanced people, you'd have an incredibly densely populated eCoMap. But this doesn't just count all your 10,000 friends on Facebook, guys, okay? This is meaningful interactions with people who would be important to you in a time of trouble. I mean, that's as Polonius says to Hamlet, those friends thou hast by their adoption proved, grapple them to your heart with hoops of steel, because those are the ones who really matter. So it's really instructive to do this for yourself. So try it and maybe then discuss it with some of the people. You'd be surprised how some people might view their place on the eCoMap and how you might view their place on the eCoMap. Don't prejudge too much. And this leads to a discussion about Health Plan 3. Now, we are running quite tight for time, so I might just go on and get this done, and then we can stop at the end and take some discussion if we need. But we will also build into this whole process regular sessions for feedback and for case discussions and reviews and all of that. So don't get too anxious about it. So this now is going on to Health Plan 3, which is an episode of illness. So your car breaking down, needing roadside assist. And here we have opportunities to look at how we have tried to avoid this situation happening, but we acknowledge it sometimes happens. What can we learn from it rather than blaming anybody? What could people do in a different way? And it looks at then about how you change and how you enhance change. And a lovely tool, which I alluded to already, is the timeline activity. Again, I talked about this last night a little. You see, this is Health Plan 1, Health Plan 2, and Health Plan 3. And it's mapped I'm not sure exactly what the colors are we're using, Davis, in the online adaptation, but there's a notion of gradation to danger. Here you are in Health Plan 1 sailing along quite nicely, and then you get exams. So under exam stress, well, you have to use some other strategies. You might need some extra medication. You might need some extra support, your tutor or your family members or whatever. And that's okay. You use those and you get better, but then all of the stressors pile up and family conflict occurs. You decide, well, to take a holiday, and you have a nice time, and things get better. But then, unfortunately, things deteriorate and you land up in hospital. And that's related also to job loss. Now, a couple of things here. One is you would look at this and you would say, oh, well, it's because of the job loss that they became unwell. Well, not actually, because what happened was they lost their job because they were becoming unwell and they weren't able to turn up to work, and they started using too much alcohol, sleeping in, being cranky with everybody at work. So they lost their job because this had started happening. And if you go back, well, there were these exams, and yes, you dealt with them, but then that and a cumulative life stressor like family conflict led to you taking some hours of well and helped you a bit, but wasn't enduring. And you didn't put anything in place after this to keep this going. Your solution was a short-term fix, and then things plummeted. So why is this important? Well, it's not a blaming thing, and it's not to say you and your mum shouldn't have gone on holiday. It was to say, well, that was a good strategy that actually really helped. However, we needed something sustained. Okay. And then you look at what happens in hospital. And then, well, here's this nice little poetic piece about engagement in OHP, and of course, everything being optimal health ever forward. Of course, that isn't the way things go in life. But, you know, it's an opportunity here to have engaged in this whole process. So this timelining I really adore, because it makes so much sense for everybody about things coming together. And we often think, well, stressors, you know, it never rains, but it pours. So life events come in cascades. Well, that's partly true on a weird level, but it's more true that most life events you sort of deal with if they're isolated and everything else is okay. So if you're driving along in your car on the nice road and you happen to have a bit of road work where it's a little bit uneven, you just steer through that and you carry on. But when it's cumulative stuff happening all the time and you haven't taken certain actions which you need to, then it becomes a problem. Does all that make sense? Anybody want to comment on any of that? Makes sense for life, right? Health plans 1, 2, and 3. So that is largely what collaborative therapy and the Optimal Health Program is around. Then there's some pieces here which I'm sure all of the clinicians are more than capable of enunciating, but it helps to understand how to have conversations, healthy conversations, coaching conversations, asking, and then working on a solutions focus rather than telling people. Building self-concordance. I'm very keen on values-based stuff and how to make decisions which are compatible with your values. How that you can't just decide stuff and things will magically happen. You actually have to do stuff. We use the analogy of going to the personal trainer and say, I want to get fit. And they say, okay, here's your fitness regime, go and do this. you come back in a week and you say, well, I'm not getting any fitter, and they say, did you do any of the work? And you said, well, I read the manual. Well, that's not really going to help, is it? So you have to actually commit to do it, and address ambivalence. And life, all of us carry ambivalence about everything. Need to keep on coming back to this, trying to understand what it is. And you can come back to other tools within this, like decisional balance, and keeping on focusing on the overall strategic direction of your values-based life direction. We would come back then at this point to visioning and goal setting, and a good point of revisiting the health wheel. If you remember the health wheel right at the beginning, we revisit that at this point. And in fact, you can revisit it any time you like, and you can repaint it, and you can see what's changed and what hasn't changed. Opportunity, one is we can monitor change, and this is a validated tool, by the way. You can also say, well, hey, great, you're doing really well in terms of your physical health, and you're so much fitter than you were when we first met, and you're feeling more intellectually stimulated. But hey, it looks like socially things aren't maybe how you might like them, and occupationally this seems to be an issue. The person might say, well, socially, honestly, I'm just putting that on hold because I was mixing with a group of people who I shouldn't have been, and they were leading me to drugs and so forth. So my physical health was a priority, so I dealt with that, and I'm dealing with that, and meant how to change my social network a bit. So it's an understanding. It's not just saying, oh, well, your social life's stuffed, so you need to deal with that. You need to understand the whole pattern of this. And then you say, well, I'm observing here, that you rating your occupational stuff quite low. So what's that about? Is that something which you would like to be dealing with? Don't assume, because that's the lowest ranking thing here on this wheel, or the most imbalanced piece, that's the thing which you have to work with. You need to understand the whole wheel, everything is interacting with each other, and really is the person's choice as to what they deal with. And then you can say, okay, let's decide what you want to do. What do you want to do in terms of your occupational stuff? How do you think you want to do that? Well, you might then say, let's look at the benefits of doing that, and let's look at benefits of what you continue to do, but also the costs. It's a bit like a SWOT analysis almost. And then you go back to stages of change. So this is De Clementi, and I still like stages of change and states of change. These are there. Maintenance is probably the most important, but before you even get to there, you have to even think about climbing the mountain. So helping people to at least even start thinking to look at the mountain and thinking it might be worthwhile to climb is what moving from pre-contemplation to contemplation. And then dealing with all of these issues and, getting people to believe that they can actually change. Because as I said at the outset of this whole OHP journey, a lot of it was responsive to people's feeling of disempowerment and loss of self-control. So if we were doing the workshop, we would go to the activity, which is a recap of a whole lot of things about where we're at and the immediate future. And then we would go through further specific visioning and goal setting. And here we use the classic technology, if you like, SMART goals. We add in the smartest, enjoyable, I think it's a really good thing, and also sustainable, and also being true to yourself. True to yourself is about being true to values. We will then have a nice celebration and general reflection, and then you ask people let's just wrap up and let's repeat all the stuff, go over what have you found helpful, not so helpful, are there any things you want to brush up on? You make sure that the person's comfortable with their health plans and their health journal, which will now be an app, of course. and then you work out how you keep things going. And then you can come back and revisit your health plans at any time. You've seen all of this, so I'm just showing you what it looks like. And then you can build in as many boosters as you like. So booster elements basically are what's going on now, and what worked, what hasn't worked. Can we review your health wheel maybe? Can we decide what are the next steps? So that's OHP in a nutshell, or in 4 different nutshells. I think we have 4 recordings now, Davis, is that correct? Which people can access, and the materials will be as you know, available to you. All of the materials I have discussed with you. So I'm conscious again for my usual problem of talking too quickly and too much, and not leaving enough time for discussion, but that is the way it happened. I accept that about myself.
But look, reach out to Enzo if you want any more information. There's information on our website. And as David was flagging, after we've got the app deployed, we'll set up a community of practice as well when people kind of are starting to deliver that. So, and we'll obviously invite you all, you know, probably about a month and a half's time for when we've got that ready, and we'll take you through again how the app works based on the OHP methodology that David's looked at. So thank you so much, David.
Yeah, the one way to find out about this is go and use it with some people, and the first few people say, look, I've got practice wheels on here as well, so let's work through this stuff together, and we can learn mutually about it, and start it with somebody who is, you know, relatively easy to work with, if I can put it that way, and who will give you a fair and honest feedback. We will, as David said, offer support throughout this whole process. We'll check in with you guys regularly. We'll provide the opportunity for case discussions and so forth in an ongoing way. Thanks so much, and have a beautiful weekend.